Okay, thank you very much for having me here today. It's truly an honor. I'm very grateful to Sarah Neville, the university here, the AHACPA board, Kees van Gool, and many others for inviting me to come here and for hosting this wonderful event. So, in some sense, I have a simple goal today, which is to share with you all a reflection of over 25 years of experience that we've had in the US in trying to innovate payment and delivery systems to try to integrate the care economy. And on one hand, that sounds easy. On the other hand, it's obviously very difficult to encapsulate 25 years of experience into 45 minutes. So in another sense, my goal here is to download to you all, to share with you all some of the key lessons, if nothing else, so perhaps going forward, you don't make all of the same mistakes that we have made over the past 25 years. So maybe I can give a little bit of historical context. So as many of you may be aware, the US spends more on healthcare than any other country in the OECD or in the world overall. Certainly in nominal terms, but also as a share of GDP. So this was certainly not lost on our politicians, and we've been trying really since the Clinton era in the 1990s to try to innovate the way that we purchase care and the way that the delivery system then pursues care. And this started first in a very US sort of capitalistic kind of way, which was the era of what we call managed care. And this was really championed by Hillary Clinton when she was First Lady, and gave rise to a set of organizations called HMOs, or Health Maintenance Organizations. And that's the managed care piece here. Oops, that's not what I wanted to do. 1990s managed care here. And the idea here was really two things. It was one, to generate greater efficiencies while producing similar health, maybe even better health in some respects, particularly around prevention, by empowering private health insurance entities to have more latitude to restrict care, to gatekeep care in certain ways, and also presumably to have the incentive to invest in things like prevention or better chronic disease management. At the same time, of course, kind of comporting with the capitalistic tendencies that are favored in the United States overall. But despite some successes, and this varied across the US geography, so for example, on the western side, California, there was greater acceptance of this HMO managed care model. Most of the country generally rejected it. And it was rejected for a few different reasons. One is, quite frankly, doctors and hospitals hated it. And doctors and hospitals told the patients that this is bad for you. And so the patients started to hate it, and there was essentially a revolt toward the end of the 1990s, and managed care was mostly, not entirely, but mostly kind of tossed out the window. And it lived on, particularly again in California, where it has continued to live over the years, and a little bit on the northeastern area of Massachusetts. So subsequent to that, we went into the 2000s, which was really what we call the prelude to the Affordable Care Act, or to the Obama administration. And during this time, there were two key events. One was in the Bush administration, there was a sizable expansion in coverage for pharmaceuticals, for prescription drugs. That happened within the government-led Medicare program, which is providing care for insurance and care for the elderly and the disabled in the US, so over 65, those with end-stage renal disease and other disabilities. And then in Massachusetts specifically, at the time the governor was Mitt Romney, put together a new health insurance scheme, which was to provide universal health insurance, but also laid the groundwork for some cost control efforts that really then grew into a federal government effort in the Obama administration in 2010, 2012 timeframe. And so now we're at this third red bullet, which is the Affordable Care Act. And the Affordable Care Act did a couple of things. One, it had something that's not so relevant for you all, which is it had different approaches to provide closer to universal health insurance for Americans. But secondly, in some ways, the less politicized and less politically charged parts of what the Affordable Care Act did is it actually set us on a path towards more experimentation in the payment and the delivery system space. So very relevant to, I think, the dialogue that's happening here in an active sense. And importantly, it gave rise to a very specific entity called the Innovation Center, which resides within the federal government, within the agency called CMS, the Centers for Medicare and Medicaid Services, which administers the US Medicare program, which is the federal program, as well as the US Medicaid program, which is actually a state-based program for low-income individuals. So this CMS Innovation Center then pushed forward subsequently a number of reforms. And I'm going to comment on some of those reforms for you so you can have some lessons learned. We've been now about 15 years into this. So it gives us an opportunity to reflect back at what has worked, what hasn't worked as well, and what we can learn from it. And in fact, much of what we've been doing more recently in the past several years is really focusing on correcting some of our own mistakes, learning from the same lessons I'm going to share with you and try to push forward. More recently, of course, we had the pandemic, which, as with you all and everywhere else, created a big shock to the system. And I think also offered us a couple of, while challenging and obviously and a lot of unfortunate loss of life, at the same time highlighted some optimism for us, which is really two things. One, there was quite a bit of resilience in the system to be able to push forward, to be able to adapt. And in the US size of the health system, so the US government programs are $1 trillion US, which is just south of 1/5 of the GDP of the US, it was pretty notable that there was actually a rapid shift in how the US healthcare system took care of people. And we adopted new programs, some of which we've learned from other countries, such as hospital at home. We've adopted a lot more in terms of telehealth flexibilities and such as well, much as you all have. So I'm going to now sort of take a step forward and try to reflect a little bit upon these elements. But before I do, let me also acknowledge a couple of things. So first, as you can see, so the top line here is the US spending on healthcare as a share of GDP. So you can see this starts in 1980 and runs all the way out to close to present day. And there has been, generally speaking, this very steady rise. We started out much closer to other developed countries, and there's been this inexorable, very persistent rise in health spending. Just for reference, Australia is this light line here. And so you can see, a much smaller share than we have. So this persistent growth is really the impetus. It's what drove US politicians and policymakers to really think about, well, we have to do something different, because in very real terms, from an economic perspective, very real terms, wages have stagnated in the US because most of the wage growth is actually being shifted into health insurance provision, purchasing of the health insurance itself, the subsidy on behalf of employees. The other thing that I wanted to just take a moment and highlight is, of course, this is not something to be proud of. And so when I speak with audiences outside the US, I oftentimes get the question, so why do we have an American here? Do we really want to learn from that? And I think it's a fair point. What I'll highlight, it's a couple of things. One is there are obviously some massive differences between our system and other nations. The majority of those differences, however, are primarily in how we provide or don't provide in the US health insurance coverage for our residents and our citizens. The way that we purchase care is actually very similar to the vast majority of the countries across the world. And so I submit to you that the reason we can learn from the US, even if we're in a different system, is because we have done in the US a lot of experimentation over the past 15 years. So I lost count at 53 models in the last 15 years that have been experimented, that have been tested in some shape or form. And we have tested in a variety of different settings. So we've tested in the hospital sector. We've tested in primary care or in the GP, general practitioner sector. This has been a really big focus here, which is post-acute care, which is post-hospital care. So what happens when an elderly person goes to the hospital and then is not well enough to go home, but is also not sick enough to need to be in the hospital? That has been a major focus in the US. Certainly a lot of focus on specialty medical care, so cardiology being a very big one, oncology or cancer care being another very big one, and then surgical care as well. So we have tested models that have been very deliberately targeted to each of these different components of our care economy over the past 15 plus years. Over time, this has really given rise to three core approaches that I want to highlight. So first, we have population-based models. Secondly, we have advanced primary care models. And third, we have episode-based models. So I want to quickly define what they mean, what they are, and then tell you a little bit about the pros and cons of each of these. So the population-based model, the idea of the population-based model is that there's an entire, what we would call attributed or delegated population. So this is a health entity. It can be a hospital at times. Most of the times, it's a collaborative of GPs that may actually engage other specialists as well, but it's very GP-led to take accountability for a defined population. And they're accountable for some aspects of health quality, as can be measured through some metrics, and also for the cost, in particular, usually the cost growth over time for that set of individuals, that patient population. The pros of this model have been that, one, generally there has been success. So quality has seemed to have improved. Cost growth has seemed to have been stemmed over time in these models, particularly in the US at least, where hospitals have not been the central entity of the model, where instead the GPs have been the entity. The other piece that I'll highlight here is that this model is not very sensitive to classifications. So classification development is much less important here because it's everything. It's all of the health spending, all of the care. So on one hand, it's very sensitive to development of methods around risk adjustment, but it's not so sensitive to thinking about things like what is included and what's not included, because everything is included, right? The flip side of this is there have also been some cons, right? Some cons of this model are notably in the US because it requires quite a bit of additional organization beyond what has naturally occurred in the care economy. It cannot be something that the federal government requires or mandates. So this has all been in the structure of voluntary programs, which has led to very non-uniform participation, for example, geographically speaking. We have seen more adoption or participation in these models in more affluent areas, less participation in rural areas, less participation in lower socioeconomic status areas. And so that's been certainly a big challenge, which over time the government has tried to address, but it is still fundamentally a challenge. A second piece that I'll note is that it's challenging to get all of the incentives right in these models. So on one hand, for the GP, it works because much of where the savings are coming to actually stem the growth in health spending is coming out of the pocket of the hospitals. But because the system is in a prevalent way paid in an activity-based funding model, many of the specialty physicians, the specialist physicians, especially those that do procedures or surgeries, they have a conflicting incentive with this model because they're intrinsically doing these procedures in hospitals. The hospitals themselves have a conflicting incentive. Hence, I was mentioning earlier that these models have not worked as well when a hospital has been a central participant. So that has been a big challenge. I'll tell you a quick story, which is the way that budgeting has tended to work in most organizations, as I understand it quite broadly. Much of the budgeting that happens within an ACO or within an organization is based on historical use. And so one of my friends, who's a cardiologist who runs a large division within an accountable entity in this program, said in 1 year, we did really well. We reduced our cardiac procedures, we reduced the spending, we reduced the hospital admissions. So the next year, I lost physicians, and I lost nurses, and I lost administrative staff. So there's no way in hell I'm gonna cut my spending next year, right? So there's a difference between what we think of as the macro incentives in these models and what is actually percolating down to the individual practitioners and the individual administrators. And it's something that I'll touch upon a little bit more in the lessons. So the second model type here is the advanced primary care model. This is very directly targeted toward GPs. The advantages of this model is that it does not actually require a lot of financial capacity or capital to participate in this model. So it's been easier in some sense to scale, although the evidence has not been very strong in the US that it has been effective in either raising quality or in improving the cost trend. And so that's been an open question. In the US, about 8%, 5 to 8% of spending, depending on which state and geography, is actually going to GPs directly. The thought is that they influence another 50% or so of health spending. And so the concept here was if we can get those 5 to 8% of our dollars to go up a little bit, but they can reduce the other half of spending, then we're in good shape. That theory has not turned into true practice here. The last model, which holds a lot of promise, is the episode-based or otherwise known as bundle payment models. And these models have been heavily targeted towards hospitals as well as specialists. These have been required by the government in certain geographic areas with considerable success. There's been greater success in some sense in containing cost growth, a little bit less evidence of real benefit for quality per se, but very little evidence that there's been any harm to quality. This does require a lot of work on things like classification, because defining what is in the bundle or within the episode can be challenging. And there's a tension here also between the cost growth incentive of activity-based funding with the concept of trying to actually stem that cost growth. The other point I'll make is that it is a pragmatic step in the direction in the sense that our hospitals use a DRG system much like yours do. And so extending hospital care to be essentially a more inclusive DRG that includes some of the cross-setting care has been something that is more incremental or stepwise than, say, the population-based models. Now, if I take a step back and say, what are the key attributes that we've been working on from a programmatic and technical perspective, I would say there's a few different elements I would highlight. So first, as I mentioned, most of the vast majority of the spending in the US is happening through an activity-based funding method. This has been blamed, probably rightfully so, for much of that cost growth I was showing you on that chart. Is that there is a prevailing incentive because there are no caps in the US on health spending. So there's a prevailing incentive for every practitioner, whether you're an individual cardiologist or oncologist, or a hospital, or a nursing facility, or any other part of the healthcare economy sector, to continue to do more activities regardless of whether they're producing efficient health outcomes. So this paradigm here, these three model types, the chief goal in some sense has been to mitigate that activity-based funding cost growth incentive. Another core goal has been to improve some aspects of how we do measurement, both in terms of classification of the types of care, but also the ability to measure outcomes that we would think, purportedly, that patients care about. So less about what is happening in a particular setting within the four walls of a hospital or within a surgical center, and more about what is actually functionally happening to patients. Are they actually improving in the health outcomes and the disability and ability that they care about? So that's been another really core goal. So that's kind of the concept behind many of these models. This has led to this value-based paradigm. And so I'll highlight a couple of things for you here. So we do call this value-based because these models, in some shape or form, link the ultimate payment that is received by some care delivery entity, usually a hospital or a collaborative group of physicians, for the outcomes that they produce, as I was mentioning. So much of this has focused still around activity-based metrics of outcomes. So things like, was there a rehospitalization after an initial hospitalization? Although over time we've gotten more sophisticated about how we're measuring health outcomes. So these value-based models have touched, as you will notice again, the primary care or GP world, which is about 10% of our system. These numbers are reflecting not the share of spending, but the share of practitioners in our care economy. 20% or so in the context of bundle payments, so heavily around hospitals. About a third of the system in some context of hospital or specialty. ACOs here are the accountable entities, accountable care organizations. So these are the collaborative groups of physicians and hospitals that come together. And then 100% of hospitals have been exposed through required programs to some kind of penalty-based program for lack of performance, and at times some bonus-based programs. But the majority of the hospital-based programs have been penalty-oriented as opposed to bonuses or positive experiences. The other thing I'll note again is this voluntary versus, so opt-in paradigm versus required paradigm. So for hospitals, it's been possible to require, even penalty-based programs. For physician-type programs, it has not been possible to do that because of the capital intensity and the lack of access to capital markets that many of these smaller organizations have. Nonetheless, these voluntary programs have actually grown pretty rapidly. So what I'm showing you here is the flagship, kind of the main population-based model called an Accountable Care Organization, ACO, program run by Medicare. And what you'll notice here, so this is 2010, and at the end here, we're much closer to present day, and you can see there was a rapid growth. And this is in terms of the number of the organizations, which hit about 1,000 before the pandemic, as well as the number of Medicare patients who are actually included in that program. So about 35 million. So that is, to give you some context, there's about 55 million patients in the Medicare program in the US. So the majority of the program was included, even though this was a voluntary paradigm. So in some sense, growth itself, growth for growth's sake, was successful. The US has used a couple of different frameworks, so I'm going to give you a little bit more context and then jump into reflections on the lessons. So the first framework was really oriented, as you noticed in the prior slide, really around growth. So can we get healthcare organizations and individual practitioners, can we get them participating in these models? Can we expose the patients not directly to these programs, but can we expose the dollars that we're spending on their care to some kind of conceptual approach, again, to mitigate this ABF-based volume incentive? And so the targets initially were focused around, can we get 30% of the dollars flowing through some kind of value-based paradigm? Can we get 85% of the dollars, and this was by 2015, exposed to some kind of link to performance? This evolved over time, and the framework has changed. This is the current framework, which emphasizes a few different things. So this is post-Trump administration, now Biden administration. And there's a couple of elements that I'll highlight here. So one, this notion of health equity became much more important. So you'll notice that I mentioned up front that one of the challenges we've had with this notion of a voluntary program is that there was lack of uniform participation. So the Biden administration came in and said, well, we need to get more equitable participation, and we need to provide incentives or approaches or technical support to be able to make that happen. Supporting innovation continues to be important, so they continue to advance new models. Certainly, a focus continues to be on addressing affordability. So there's some commonality, some common themes. The other thing that I'll highlight that you will notice, so I mentioned here that a lot of the focus was around hitting these targets. And these targets were actually hit, as reflected to some extent in this growth that we saw. One of the interesting things that we have observed is that the government did a very good job of signaling to the care economy where it was going through these targets. We are going to try to expand in this way. We will try to do it through voluntary means if possible. If not, we will resort to more required or mandatory means. And so one of the interesting things is if I took you back to the US share of GDP slide where the US was growing very rapidly, there was actually somewhat of a flattening that came before the pandemic. And there's a lot of debate, don't get me wrong. So there's a lot of debate about why that may have happened. I would say at least a few of us have argued that there have been some effects from this approach of signaling and adoption of these models that have this core intent of trying to mitigate this ABF growth incentive. And so while each individual model has sometimes succeeded and sometimes failed, there has been this system-wide recognition that the US is moving the whole care economy in this direction. And that is one of the reasons we think that we have seen some of the flattening, and one of the reasons that we think we've seen growth despite the government not mandating participation in these models. So that signaling has been a really important part of the narrative of the last 15 years. So that brings me to my lessons. So the first lesson, savings take persistence and time. And I'll show you some data about this, but most of the programs have taken several years before they've actually achieved savings. Now that is different than saying, have they been successful in changing the way that care is delivered? Care is delivered, that dimension has changed more rapidly, and I'll show you some data about this. The second piece is test with purpose. And I'll talk a little bit more about this, but in the US, we tested, as you can tell by the numbers, 53 plus models. We tested largely in that first phase just to see if we could test. Could we be successful in testing? And that created a number of downstream complications and ripple effects, and I'll share a couple of those with you. The third lesson is plan with scaled implementation in sight. So we scaled, or rather we tested a number of different models, some of which were in those three buckets that I mentioned to you: population-based, advanced primary care, episode-based. In isolation, when we looked at those models, they looked like they made a lot of sense. But when we tried to scale them together, they begin to conflict with one another. And that created a problem. The other issue is that some of the types of innovations that we stimulated ended up being very difficult to scale across all geographies, across all populations. So a core lesson there was really think forward when you design the model that you're going to test. How are we going to scale these models, even if some of them don't necessarily succeed? The fourth lesson is use behavioral science to align incentives. And what I mean here is coming back to that lesson I was discussing about my cardiology friend, which is sometimes we can get the macro incentives right through good evidence-based payment policy. But that doesn't mean that the way that the organizations are functioning at the individual patient interaction level are the incentives at that level are aligned with the macro incentives. And what behavioral science has taught us over the past 50 years is that there are ways to transmit those incentives more effectively such that each incentive dollar that we spend has more impact on the outcome that we care about. The last lesson here is establish and leverage active feedback loops. Much of this is very pragmatic, which is if organizations and clinicians in the models don't know how they're doing, it's very difficult for them to succeed. Some of this is also much broader in the sense that even policymakers need feedback loops. And some of this requires engagement from other stakeholders. It's been very successful in the US to engage academic universities and other delivery systems to provide an engine of feedback that is very rapid and very continuous so that we're not just relying on the government evaluations themselves. And I'll share a couple of examples there as well. Okay, so let's dive into these lessons. So savings takes persistence and time. Okay, so this again is the core program on the population-based side, the Accountable Care Organization or ACO program. It's the same one that I showed you the chart where there was rapid growth in the 2010s and we got to 35 million patients, right? Same program. Okay, so now that I've oriented you to that, what we have here on the y-axis is the savings in dollars, US dollars, and then we have the year. 2013, which is pretty close to the first full year that the program was in effect, all the way through much closer to times, 2021. So what you'll notice is that in this kind of gray-blue color, we have gross savings in this program, the Medicare Shared Savings Program, or MSSP. And in the green, we have net savings. So what this means, gross savings, is saying, let's just look at the dollars that got spent. Let's not focus on program administration costs, and let's not focus on any bonuses or penalties that were paid as part of participation. So in some sense, that gray-blue color is really giving us a sense of, so how rapidly did the care economy start to change the way that it was delivering care in response to the incentives? So what you can see here is actually right away, starting in year one, for those of you on this side. So right away, you can see that there was actually immediate change and pretty rapid change in the way that healthcare is being delivered in a more cost-efficient way. To the federal government, however, the green was the relevant metric of savings. So here you can see that it took 5 years before the federal government started to see any savings from the program. So rapid change in practice lagged change in savings to the government. So now this is not true for every program. Okay, the bundled payment programs actually saw much more rapid both gross savings and net savings. And the reason we think for that is because it was much more feasible, it's much more tractable for hospitals to understand what they needed to do. They were also much more targeted in where the savings were going to come from, and I will touch upon that as well. At the same time, so it wasn't all just success. There were also some other learnings here. So on one hand, as I mentioned, a lot of these programs were voluntary in nature. So they allowed participants, in this case hospitals, to either be early adopters and start early, or to be later adopters and to say, well, let me see how others have done, and then based on that, let me join. And this led to what has been pretty universally described in the US literature now as this kind of early versus late adopter phenomenon, where you have the early hospitals, so early savings, early hospitals, early entrant hospitals here, are the ones that generated savings. And the late entrant hospitals didn't. So 0% means no savings, and these are the confidence intervals. So we can see that early entrant hospitals are the ones that generated savings, and the later ones didn't. So this was another challenge of this kind of voluntary paradigm. So a couple of thoughts, a couple of recommendations. So one thing is having staged milestones and pre-planned assessment is fundamentally important because sometimes the savings can lag relative to the care delivery changes. So we are dependent on positive savings to continue to sponsor the program, then it can be very challenging if the timeline is 1 or 2 years, right? And so we can protect against that by actually having staged milestones and pre-planned assessment, and then of course unmitigated resolve, right? We have to say we're going to do this. We have to signal also to the care economy what the changes are going to be. Test with purpose, lesson number 2. Okay, so in the US, lectern for a moment here. So in the US, there was a recognition over time, and this was really led by an academic institute called the Dartmouth Institute, which produced something called the Dartmouth Atlas, which was looking at where do we see geographic variation in the US, in the type of care and the cost efficiency of the care. And one of the areas that there was a very obvious variation was in this post-hospitalization period, where, and you can see the differences between the dark and the light regions. And the numbers don't matter so much. These are reflections basically of various kinds of inefficiencies. But what you will notice is there are some light areas in the US and there are some dark areas. And this is an example where we're looking after a hospitalization for a medical reason and what share of the population in the Medicare program are actually receiving appropriate follow-up care with the GP. Okay, that's what this is here. And so a couple of things. One, I'll show you a number of charts that kind of highlighted this, but I wanted to make 2 points here. One is this highlighted an area where the academic stakeholders, the academic community actually made a really fundamental impact on the policy-making community. Because this basically identified an area where there was a lot of opportunity to generate more efficiencies without compromising care quality. In fact, there were opportunities to improve care quality while generating savings. And this did not come out of a government research service. It came out of an independent academic institution. So that was very important. The second thing is it did very clearly provide then a target for policymakers to go after. And so this is where the bundle payment models have been targeted. So I mentioned to you earlier that some of the savings came faster in those models. A big reason for that is there was obvious opportunity. And that opportunity I can show you in a number of different respects. So that was whether a GP saw a patient. This is now rehospitalization within 30 days of the discharge. Again, the darker is the worst performance, and the lighter is the better performance. And you can see a lot of variation across the US. If we look at emergency room visits after the same medical discharges, so these are heart attacks, strokes, these kinds of admissions, you can see a lot of variability. I'll step through these relatively quickly. This was also true in the surgical context. So after orthopedic surgery or heart bypass surgery, a lot of variability in the rehospitalization, in the general practitioner visits in the 14 days afterwards, emergency room visits within the 30-day afterwards. So again, a few different lessons here, but one of the key ones is if we can target exactly where the opportunity for better quality and savings are, then we can design the models in a way that are directly affecting those. Next one here is plan with scaled implementation insight. So here, we actually have a nice example that should resonate with many of you, which is hospital at home. So hospital at home is a paradigm. Many of you may be very familiar with this, as much of the work that we've done, we've actually looked over to you in Australia to see how it's happened, and then we've built on that. But the basic idea is, instead of receiving hospital level care within the four walls of a facility, can we use technology and remote services, people visiting, to actually provide that same level of care? And so there's sort of a circular pattern here. There's also a greater role for the patient caregiver. So I won't go into details of the specifics of this diagram or model for the sake of time, but I'll highlight a couple of things. So the first is, hospital at home is not new, at least not new in the context of the types of reforms and the period 2010 onward that I was discussing. The first Australian and US hospital at home programs, or at least concepts, were starting to develop in the 1990s, right? But what happened in the US, actually subsequent to that, is two medical centers, Mount Sinai Hospital in New York City and Brigham and Women's Hospital, which was part of the Harvard Medical System in Boston, Massachusetts, developed their own programs. And the reason they did it actually was in part for their own financial reasons. So they tend, as they are in big cities, to be very high occupancy hospitals. And they found that if we can move some of our low acuity patients, or low intensity patients, outside of the hospital, we can make more space for those that we get paid more for and that require the specialized services that we can provide. So on one hand, it was with some sense of civic duty, but a lot of it was from just pure financial profiteering interest as well, right? The point being that they developed this model. And then later, the US government came through and said, well, we should turn this into a demonstration project, which is our word for a pilot, basically. And so we started a model, and then the pandemic came, and then actually the government just scaled the program instantly and said, if you have the capacity to perform this, you can participate in this model. And to this day now, actually, it's a question whether at the end of this year, end of 2024, whether this hospital at home program, as funded by the federal government, will continue or not. Technically, in law, it's slated to end in 2024. It's quite likely that the US Congress will extend that program beyond this time frame. But it illustrates a couple of things, this example. So one, it illustrates very nicely, again, how the sort of hospital, non-government sector, in this case, academic hospitals, played a very big role in developing and defining a model that was not a financial model, but a care delivery model, then was adopted by the government and financed and funded by the government. So it wasn't the government having to figure out exactly how the care model should work. That was a really big success in the US from that perspective. The second piece it highlights is that because it was developed in practice, in the actual process of caring for patients, it didn't have this problem as other models did of how to scale it and how is it going to work in practice. It was not just a test case. It was something that was actually being run in the real world, so to speak. And so when the pandemic came, there was not concern in the US so much about the feasibility of scaling this funding model. In fact, there wasn't, because it had already been developed by the organizations themselves. So it's a nice reflection of this kind of plan with scaled implementation, particularly in a multi-stakeholder kind of capacity. Okay, I'm going to push us forward for the sake of time here. So I did mention also that there were some unintended effects, right? So we've done some writing here, which has basically noted that as these programs were developed kind of in silos and then scaled, they started to interact. They started to bump into each other. And one of my colleagues, Robert Mechanic, very nicely wrote, what happens with these payment systems collide? And they created complications for accounting for the government, how to compute savings, which program is doing what. It also created a big problem in knowing whether any single model was working. And this was, and article that I wrote, which basically highlighted that when we looked at each single model's evaluation and we look at the control group, the kind of reference group, we saw that the reference group itself was doing better over time. Most likely because the reference group for this program was participating in some other program, right? So we created this system where it became very hard to actually achieve success in any given single way when at scale, as evidenced by that flat trend, we actually thought at scale we were having success. And so there are some idiosyncrasies there that I won't get into about US specific policies on authorities to scale, but it created quite a bit of complication. And instead we've argued then that there should be a more coordinated approach. So again, thinking about even if we're testing particular sectors, how are these models eventually going to fit together? That thinking has to be done up front, not after the fact, not after we've let all the horses run and then decided which ones win and which ones don't. Use behavioral science to align incentives. So we are in a university here. I couldn't help become a little bit of a university lecturer. And so you'll notice that I have a number of different principles here. For the sake of time, I won't go through each of them, but I'm happy to share these slides with all the participants. The general point I wanted to make again, and I'll come back to this slide in a second, is that we can use behavioral science to align what I'm going to call here micro incentives, which are what is happening within the organization, what's happening at the individual level, even those that are invisible, right? Even those that have more to do with how the organization makes decisions, allocates budgets, even those have to be aligned with the macro incentives for this to work. And I'll share an example actually from Singapore where this was a problem there. So there are a number of ways in which humans make systematic, what we might call decision errors, or use heuristics to make decisions that don't comport with traditional, rational, neoclassical economic theory. And there's a few of these here. I'll highlight just a couple to keep us moving. But some, for example, just giving people information alone is not enough. Right? We need more than just information to drive behavior change. A lot of choices actually can be stilting rather than empowering. People in general respond, and organizations, by the way, respond very strongly to losses, to penalties, more than they do to bonuses or gains. This is a big one. So we intrinsically, as humans, tend to care very much about how we rank relative to others. And so together with a colleague of mine, Zeke Emanuel, we've done a lot of work that has actually shown how powerful just showing comparative data is in generating practice change and performance differences. So I'm going to skip through this, but again, I'm happy to share these with you. So the last lesson here is establish and leverage active feedback loops. And I think this is important for care organizations and clinicians. It's also very important for policymakers. Again, because oftentimes formal evaluations lag. They take time to do. And so unless we have ways to actually feed back performance, it's very hard to get the system to shift in a time frame that we ideally want it to shift. So over time, we have developed a variety of different dashboards. This is actually something that we developed together with a private insurance company in the US, which basically showed some relative social ranking. How are you doing relative to your peers on a performance metric? Actionable information, what is the top 10 list of things that you should be doing? So trying to be a mix of here's how you're doing relative to your peers and here's what you can do to do better. And so this activates some of those behavioral science principles I was mentioning as well. Relative social ranking, social pressures, another one that's in here. And notice, of course, a lot of feedback. The other point I'll quickly mention is that policymakers need feedback too. So in the US, when we started the bundle payment models, there was a lot of concern that are we really mitigating the spending growth incentive of activity-based funding? Maybe we're just going to put it on steroids. Maybe we're going to make it even stronger because the dollar sizes for each unit of purchasing is going to get bigger. It's going to move from 10,000 US dollars to 50,000 US dollars. So there was a widespread concern about this. We tried to do a study very quickly to show, in fact, that there was not any effect. I won't go through the details of this, but you'll notice there's no big changes here. There was actually no change in the amount of activity in response to this bundle payment program. This was meant to look at what are the characteristics of the patients, their age, whether they come from a high income area or not, whether they have depression or psychosis, whether they've used a hospital before. Again, what we found is that there were no big changes. So we were able to quell a lot of the concerns that were coming, and that empowered the policymakers to continue to push forth and scale these programs, which they've continued to do. Subsequent to this, there have been multiple evaluation reports funded by the government that have corroborated this evidence, but we're able to give it to them on a time frame that they would otherwise not have been able to get. So I mentioned that other countries also have had similar lessons, and I'm going to then wrap up here. So in Singapore, where I've had the good fortune of working for the better part of the last decade in an advisory capacity, they've also noted that they've had this increase. Now, admittedly, these numbers as a share of GDP are much smaller than the US numbers, and in fact, than even the Australian numbers. But they did see this spike over time. And they started to get concerned, and very interestingly, they told me, we have, like US, we have an activity-based funding problem that's fueling our growth. And I paused, and actually I thought to myself, this is crazy, because they don't pay in an activity-based funding way. They pay in a block funding way. So how, if you're playing in a block funding way, can you say that we have an activity-based funding, or fee-for-service as we call in the US, problem? So it turns out it all has to do with the internal economics of how the organizations budget. And just like I was describing to you that cardiologist who said, there's no way I'm going to cut my spending next year, they had this happening at each hospital region level, and then at each department within the hospital. So in order to maintain the influence and the power within that structure, the organizations, despite having a block-funded model, continued to grow. Some of it has to do with the way that the formula works, which I won't get into. But nonetheless, there was no actual activity-based incentive, but because of the way the internal dynamics worked, they had an activity-based result. I will skip the Netherlands just for the sake of time and leave you with one broader thing. So my meta lesson here is, at the end of the day, the one thing that we've learned is the efforts just to mitigate these activity-based funding incentives for growth, which are really prevalent in the US as a phenomenon, to integrate the care economy, to do the many things that you all are trying to do. We have found that any given incentive system that we use doesn't work in isolation. But rather, we've had to find a way to stitch together approaches. And so this is actually something I stole from a colleague of mine, really a mentor of mine, Martin Rowland from the UK. Some of you may know him. He led much of the work evaluating the UK performance schemes for primary care and hospitals and the like. And he showed this to me once, and we made a slide out of it, which is basically, if you think about the incentive in each of our different core models, we end up with something silly, right? Something that seems stupid. If we're in a salary-based model, then the incentive is to do as little as possible for as few people as possible. If we're in a capitation model, then we want to do as little as possible for as many people as possible. If we're in an activity-based or fee-for-service model, we want to do as many tasks as possible, regardless of whether the patient's getting any health benefit or not. And if we're in a performance-based payment system, then we want to do the tasks that give us compensation, that give us the bonus or that we get paid for. And so each of these paradigms in isolation has its problem. And so those three linchpin models I mentioned that have bubbled up in the US, the key thing I'll highlight about them is that they borrow elements from each of these. None of them is purely a capitation model. None of them is purely an activity-based model. They're trying to blend things together. Thank you. I'll stop here.